Well, the recent release of the second validation study at San Antonio was pretty impressive. And I think it's extremely important to move from a smaller study like ECOG 5194, which was previously presented there, to this much larger cohort of women from Canada to show that it really does cross from what was thought to be a lower risk population to a standard population of women with DCIS that present every day in our clinic. So I think it's going to be extremely important in moving it forward, and I imagine that the utility is going to increase significantly with this data.
The Oncotype DX DCIS report gives me a lot more confidence that I understand the biology of that particular lesion, at least in the sense that I understand its risk for coming back in the absence of radiation treatment. We know from very large randomized trials that radiation therapy dramatically reduces the risk of local recurrence, and there is no impact whatsoever on survival. So it's a great conversation to have if you can empower that conversation with information.
I think the way we consider DCIS is that we've always considered it as one disease, and yet it clearly isn't. We have different grades, but now also we have different recurrence scores, and so we've been able to see, just like invasive cancers, there's a big spectrum.
As a physician, you definitely worry about your patients, and you take a lot of responsibility for what's going to happen to them in the future. Because of that significant responsibility, you worry and you want to make sure you don't miss out on giving them what they need, because the last thing you want is for them to have a poor outcome in the future.
For me, the clinical role is to empower women, to inform the discussion about the benefits and risks of radiation treatment in their case. And if you get an individual estimate, that really helps many women help make a decision about what they want to do.
So what I say to a colleague who hasn't ordered the test is, do you not come across patients in your practice with DCIS that you're uncertain how to treat them? Do you not want the most information you can get on that DCIS for that patient? If you do, then this provides you with information you can't get from any other test.
I think in the past we've used terms like 1/2 or high risk or low risk. Now we can really say it looks like your risk within some limits is 10% or 15% or 20%, and we think that may go down to half of that or a little less with radiation.
Now with something like the DCIS Oncotype score, it really gives you the confidence to make that decision and not worry about how you treat those patients, and really feel confident about omitting certain therapies, where in the past you would have been extremely worried about that and what might happen in the future. So they feel confident, and it's just a much better way to move forward.